So welcome to our annual Fall Implementation Science Seminar Series. My name is Dr. Alethea DeRogers, and I'm an assistant professor in the Department of Psychiatry and Human Behavior at Brown University, and I have been hosting the Fall Seminar Series. Our Implementation Science core in the Department of Psychiatry and Human Behavior at Brown University has recently rebranded as the Brown Research on Implementation and Dissemination to Guide Evidence Use, or BRIDGE program. This is the 6th year of our implementation science programming, and we are thrilled to be able to bring these seminars to our Providence and Rhode Island community of implementation scientists, as well as to those of you who are joining us from other states. We are grateful for the partnership of the Advanced Rhode Island Clinical and Translational Research, or Advance-CTR, for supporting the technology, logistics, and marketing of these seminars. And we also recognize our partnership with the Brown Alcohol Research Center on HIV for their support. I'm pleased to introduce Dr. Natali Carmio, who is a PsychD and MPH and the Empower Program Manager at Harvard Medical School. She is committed to implementing real-life interventions that foster positive change in the lives of individuals and communities. She is a passionate advocate for enhancing mental health and well-being at a community level. Her experience as a health professional in a public hospital in Buenos Aires, Argentina, her hometown, has contributed to her deep understanding of public health challenges and the importance of accessible healthcare services. Embracing new and innovative technologies, she seeks to leverage these tools to ensure concurrent and prospective care, reaching those in need of mental health support, especially in low and middle income countries where access to mental health services is limited. The title of her presentation today is Empower, Building the World's Mental Health Force, Lessons Learned from India and the US. As a reminder to everyone, you can put your questions in the chat function throughout the seminar, and we will hold some time at the end for Q&A. And thanks so much, Dr. Carmio, again for joining us, and I will turn things over to you now.
Yeah, thank you, Alethea. Thank you, Trish, Steve, and everyone at Bridge for this invitation. I'm very thrilled to be here to talk about Empower and implementation science. As mentioned, I'm Natali Carmio. I'm the project manager and program manager of Empower, which is a non-for-profit effort here at Harvard Medical School, led by Dr. Vikram Patel, who is the chair of the Department of Global Health and Social Medicine. And I'm going to talk about our work in building the mental health workforce. As you are all very much aware, we are currently ongoing a global mental health crisis, mostly driven by the high prevalence rates of the most common mental health disorders, such as depression, anxiety, and so on, and also in parallel, the scarcity of mental health professionals that are able to provide care. This results in a lack of access to quality care for most of the people around the world, especially in low and middle income countries, but also in high income countries, but in low resource settings. People that do access treatment, they don't necessarily access the treatment they need. Most people access medication treatment and not psychosocial interventions. Psychosocial interventions have been proven to be one of the most effective and the first line of treatment for most of the mental health concerns, such as depression, anxiety, PTSD, and so on. And it has been proven to have better outcomes in the long-term recovery with fewer relapses. So, and on top of that, people usually tend to prefer psychosocial treatments, but they don't get to access this. And the question is why? We have put together 3 main barriers that we think are challenging people to getting real quality access to mental health treatments. These 3 barriers are content, especially because psychosocial interventions are very complex packages that require a lot of extensive training, which is always time-consuming and also very resource-intensive. The barrier related to supply, that is, as I mentioned before, there is a scarcity of mental health providers, but also the fact that these providers are distributed in a non-equitable way across different contexts, and in low resource settings, it happens that in some settings, for instance, there are like 1 psychiatrist per 1 million population, or 1 psychologist per 500,000. So it's impossible for people to get access to specialized care. And finally, the quality barrier that talks about that even when you do get access to treatment, quality assurance is very hard to get, is also very expensive, resource intensive, and is most of the times not done properly because of very time-consuming methods that cannot be scaled up. So at Empower, what we are trying to do is to address these 3 different barriers with different methodologies and techniques. The first one is how we solve the content barrier, and through like the last 10 years of training, it has been found that brief key ingredients can be used to address psychosocial concerns. So we don't need like very complex packages to address community, like depression in community settings and so on. The second barrier that we are trying to solve is the supply barrier. And now we have more than 100 randomized controlled trials across the world that show that frontline workers, lay professionals, can effectively deliver mental health interventions, as well as delivered by specialist providers. Finally, quality barriers can be addressed with the leverage of digital technologies. We can use, and we have been using digital technologies to provide quality assurance by peer support and peer measurement-based supervision, as well as fidelity checks. So Empower is a digital solution for learning, mastering, and delivering quality assured psychosocial interventions. And our mission is to empower anyone, everywhere, to master and deliver the delivery of evidence-based psychosocial interventions. How we do that? Based on Paul Farmer's accompanying model, we believe on accompanying the trainer and the provider through the learning journey. And we all know that mental health is a very complex field, and just taking a training is not enough. So we create trainings, but we also create a life learning journey, and we accompany providers through that journey every step of the way. The first step, as you can see here, is the training. It's a digital training that is competency-based, and providers or trainees to take that training at their own pace, because these are digital trainings, but they do have remote coaching support. As a second step, once they finish the training, they take knowledge assessments, which are basically multiple choice, standardized, validated measures that are created specifically for that training, and that help us assess how these trainees are doing on specific knowledge questions that are practice-based. Once they complete the knowledge assessment, they go through an internship phase where they can deliver the intervention they have been learning with supervision from an expert. And once the internship phase finalizes, they go through a skill competency assessment, which is a standardized role plays that we develop with the support of the WHO based on what they have created in their QUID platform, but we adapt it to our own trainings. And that's the last step that the trainee has to take in order to become a credential provider. Once someone is credentialed, they will continue to deliver the intervention in real life settings. But we believe in the importance, as I mentioned before, of quality assurance and fidelity checks, and also supporting the provider to avoid burnout, and to ensure that the treatment that they are delivering has the necessary quality for the client as well. So we have created a measurement-based peer supervision system The goal of this model of supervision is that we create a model of supervision that could be scale up. So peers, colleagues from the same organization that have been through the same training meet weekly or bi-weekly or monthly or in the frequency that they are allowed to. And we have created a new app with the Dimagi team, and I will speak very briefly about this later as well. It's an app that people can record the sessions, providers can record the sessions that they are delivering. The same group of the peer supervisors listen to the session in advance to meeting for the supervision session and rate that session according to a standardized measure that's also was also created specifically for that intervention in particular. So once they meet, they have rated the session that's randomly chosen each week, a new session. They have those ratings. They can discuss those ratings. They can bring consensus on different points and also discuss how to enhance and improve their sessions and the quality of the treatment they are delivering. How do we select interventions? And I think this is something that sets us apart from all other programs, is that we are very rigorous in the selection of intervention process. This means that we only use non-proprietary open source manuals. And the way we choose these key ingredients that we select to be digitized goes through an extensive process. First, we conduct a scoping review, an umbrella review to make sure that we find those key ingredients that have enough randomized controlled trials in real-life settings delivered by non-specialist providers to ensure that the key ingredients that we choose are the ones that are most effective for that particular concern, mental health concern. Then we also, for each of the interventions that we create, we gather an expert group, and this expert group is both includes both academic experts, but also experts by experience, that like people that are working in the communities we aim to serve and can bring us also their expertise about how we should undergo this process. And finally, something that I'm very proud of is our participatory approach. We include people, we co-create all the content with the people from the communities that we aim to work with, and we incorporate them in the decision-making process. So for selecting one intervention to be digitized, that particular key ingredient or intervention should go through all this process. The next step for creating our curriculums includes the actual creation and digitalization of the curriculum. This goes first, we have the blueprinting process, which is creating a syllabus that has the different modules that curriculum will include with the learning objectives of each module. And once we have that, we start scripting the videos that are going to be incorporated into the trainings, as our digital trainings are very video-based. We also create all the supplemental material, worksheets, manuals, and everything that needs to be supporting the trainees through the learning process, but also when delivering the intervention. Once we have those materials, the scripts go into a video production phase. And once we have the videos, we incorporate all the different content into a learning management system, which is basically a digital platform that can be used for people to access the different trainings and see the videos and access the supplemental material and so on. And with that, we also conduct formative testing, that is go into the communities that we are working with and ask them to review the whole training and provide us feedback to ensure that we are able to improve the feedback, improve the curriculums with the feedback that they give us. So this is the general methodology that we have developed and we use for each of the interventions that we create. And as I mentioned before, we use technology across our deployment, because we believe on leveraging technology to improve the scalability of the curriculums that we create. So all the curriculums, as I said, are digital on a learning management system. The coaching protocol, that is the person that will support the learnings and send individualized messages and motivate people and office and extend office hours, invitations, and so on. All that can be done either digitally or remotely. The knowledge assessments, which are the multiple choice tests, can also be delivered remotely, and the competency assessments can also be delivered through Zoom or other platform. And we are also trying as a test now some asynchronous versions of competency assessments to see if we can use them to also help scale up our trainings. As I mentioned before, the supervision piece is also being able to be done remotely, and with the support of an app that's being created with the Maggie team to ensure measurement-based quality supervision. And finally, all these different steps produce a digital blueprint, digital data that we can collect and use to produce feedback loops that can help us improve our trainings and improve every step of the way of the curriculum. In terms of the work that has been done in India, the first thing was to create the training that was delivered to the community health workers that are called ASHAs in India. So we took the healthy activity program that you can see the manual over there, the manual cover, and we adapted for it to be used in India, and also we went through the digitization process. As I mentioned before, we believe in the collaborative approach and co-creation of content. So we invited ASHAs to help us throughout this process of adaptation of the manual and digitalization. And they conducted focus groups, workshops, and we also created different prototypes of potential curriculum and collected feedback on which one was most suited for this context. As you can see there, one of the prototypes was an animation. At first, we thought that animation could be the way to go and could help us in the creation of curricula, but collecting the feedback and talking to ASHAs, we found out that the animations that we were able to produce didn't have the quality of Disney or other animations that we are all very used to watching, and they prefer real life actors that can feel more engaged to and represent more easily. So that the whole training and curriculum was created and is currently being deployed in these 3 different districts. You can see the population there. And so far, this year, 1,000 ASHAs have been trained. And these are the results of the current deployment. 20,000 people approximately were screened. 2,500 were screen positive for depression, and 13,000 sessions have been delivered. 2,500 positive screens is a high rate, is a high percentage. It's almost 10%, and it's more than general population. And we believe this is because ASHAs are already working in their communities and know and can target a little bit better who to screen for. And also this talks about how much people trust the ASHAs and their community health workers and are able to share their mental health concerns, even considering how stigmatized sometimes mental health is. And in terms of outcomes, the baseline, the PHQ-9 is a mental health measure for depression that is like globally used and measures the level of depression of a person. So the baseline PHQ-9 score of the people that were screen positive was around 14, which is a moderated level of depression. And the endline PHQ-9 score after 6 sessions of a healthy activity program cut off by half, or more than half. So we are very excited about these results, and we look forward to what's coming next year when we continue to scale up and more patients are enrolled in our program. And this is one of the pictures of a peer support supervision that I mentioned before, where the ASHAs come together bi-weekly. Before that, they rate the session that they are going to discuss on this particular supervision. And once they come together, they discuss the ratings, they discuss how it can be improved, and also share some common concerns or different kind of challenges they could have found. In the US, The first thing we did was to adapt the healthy activity program to a behavioral activation program, also for depression. And as I mentioned before, we are very into the collaboration and co-creation with communities. So we conducted a formative testing. We incorporated 22 participants, 13 were non-specialist providers and 8 were specialist providers with our partners in Texas, Meadows Mental Health Policy Institute and Baylor Scott and White Health System. During the formative testing, participants went through the whole training, and we also collected demographic data. We were mostly interested in knowing their background in mental health training or in delivering mental health interventions. We also asked them to complete a satisfaction survey that went through the content, the supplemental material, the worksheet, the structure of the training, the navigation system, and so on. And finally, we conducted focus groups to get more in-depth feedback. From those focus groups, we were very excited to hear what they have to say. They really liked the content and the content structure, especially the role plays, because they felt that the role plays were very realistic and showed them how to actually apply the skills that they were being taught in a real life setting. They also enjoy very much all the interactive activities. We have matching and we have true or false and so on. So we help learning through interactive activities, help people get engaged. And also we were very happy to hear that they thought that these trainings will help them deliver holistic care. And also they felt that the content was very non-judgmental, which is something very valued in the mental health field. In terms of the navigation, the LMS system and the technology, they said that it was easy to use, intuitive, and they found no major problems using the content either on their laptops or in their phones or on iPads and so on. And then we got some suggestions on things that we could improve on our training, such as, for instance, creating a roadmap at the beginning of the training or incorporating more interactive activities. And so we took all that feedback and we went back to our trainings and changed the whole structure to make sure that we were incorporating the suggestions that we got. Once we had the final curriculum developed, after incorporating the feedback from the formative testing, we finalized this year a pilot study to test the preliminary effectiveness, the feasibility, acceptability, and satisfaction of the behavioral activation curriculum. These were the methods. It was a very long study. Participants, after recruiting, they, of course, signed a consent, but they also did a pre-knowledge assessment. We developed 3 different types of knowledge assessments, which are these multiple choice questionnaires. So people were randomized to one of the 3 versions, previously to take it in the training, but also post. So we could compare and we make sure that nobody got the same version twice to avoid learning. So they did the baseline survey. Then we give them 6 to 8 weeks to complete the foundational skills and behavioral activation training. And once they completed that, they did the post-knowledge assessment, the satisfaction survey, and also we invited participants to join the competency assessments, which are the standardized role plays. And as I mentioned before, during this pilot, we tested both synchronous and asynchronous versions of these competency assessments with the idea of finding out if we could use asynchronous versions of competency assessments that could make this more scalable. We also, in this pilot, included the Dimagi app for measurement-based supervision. So participants were invited to play with the app. We pre-recorded 2 mock sessions, and participants were able to rate those sessions using the app. And then we invite them to join focus groups so they can provide feedback of the whole process and how we could improve this process. In terms of the participants, all the participants were working at Baylor Scott and White Health System and were recruited there. Here you can see some of the data. We were very excited to find out that a wide range of frontline workers were interested in taking our training, not only community health workers, also, as you can see, nurses, medical assistants, and also admin staff. And also we were excited about the high retention rate. Almost 70 participants that signed up finalized the whole pilot study, which was very exciting for us, considering that participants were doing this in volunteer basis on their free time, and it had many steps. So we were very excited to learn about that. In terms of the results, the knowledge assessments, of course, this is not final, but the participants that completed the training had significantly improved after the training, whereas participants that didn't complete the training or didn't start the training, they didn't have a significant change on their knowledge scores. And in terms of the satisfaction survey, most participants said that the training was comprehensive, it was easy to learn, easy to follow, that it was an effective manner of learning mental health concepts and interventions, and the language that was used was easy to follow. This summarizes a lot of the feedback that we got from the focus groups. I just want to highlight that people really enjoy and appreciated the coaching protocol, which is the person that sends weekly individualized emails and helps the office hours so people can join if they have any questions. Also, they mentioned that the synchronous version of the competency assessments felt more realistic, which is clearly something that we need to improve on the asynchronous versions, as it's not very common for us to self-record in a session. And then they also provided feedback. For instance, some people suggested we created manuals to complement the trainings, and we are finalizing those as we speak. And also some improvements that we could do in some particular modules that we have created, where a provider is delivering the care in not the very best way. So we ask questions about like how this can be improved, what's the provider not doing as suggested, and then we provide a better version of the session. So that type of module was very valued by the participants. And finally, as I mentioned before, we included these participants in the adaptation process of the peer supervision app. And here you can see some screenshots of how it works, how you can rate the session on different skills, both foundational skills, general skills like empathy, warmth, confidentiality, and so on, as very specific skills that are related to the intervention itself. And then this app also allows to track how the trainee or the provider is doing across the time. So you can measure how someone is performing on different competencies across different moments of the year, and also to track the PHQ-9 that measures the level of severity of the patient across time as well. And we will continue to work on this app to improve it and make it available. And finally, the content of the behavioral activation training that's already finalized and it's ready to be scaled up. We also aim to translate and to adapt it to Spanish for the Latin American population in the US. And for obvious reasons, I'm very excited about this project. And as I mentioned before, we went through a very rigorous process that included collaboration and co-creation with the communities. So the first step for this process was to engage 10 bilingual community health workers in South Texas, and they review foundational skills and behavioral activation. We provided them with a very detailed guideline of the different things we wanted feedback on that range from settings, actors, vocabulary that was being used, problems that were being addressed, how we could adapt it and tailor to be culturally responsive and also to feel relatable for the community health workers and the population that they were serving. Once we got that very detailed individualized feedback, we also asked the bilingual community health workers to join us in focus groups discussions because we wanted to discuss, we put together that information, but also to discuss some other ideas, how we were going to talk about mental health in Spanish, the specific wording that we were going to use, how we are going to call community health workers in Spanish so they feel related to, and so on. Once we had all that feedback, we went into the adaptation of the scripts. That it wasn't just a translation, it was a cultural creation. Like we recreated the scripts, adapting them to the Spanish language, but also to the Latin culture. And currently the videos have been produced already. We are doing 2 rounds of reviews of the videos. We are finalizing that process now. We are also working on the adaptation of the knowledge assessments, the competency assessments, the measures for the supervision piece, the worksheets, the manuals, so everything that comes in a curriculum. And we are going to put that together soon into an LMS system and hopefully start deploying the Spanish curriculum in the next month or so. These are the other curriculum offers that we are creating at Empower US. We have Empower Youth that aims to train community and school personnel to address youth anxiety and depression, especially in school settings. And we have decided with the expert group and the communities to create a step care curriculum that will have a first encounter that incorporates relaxation techniques, and then problem solving as a second step that can be offered to the youth as well. We are finalizing the scripting as we speak. And once the scripts are finalized, someone from the APA, American Psychological Association, will do the expert final review of those scripts, and then we will go into video production. We also have the Peer Support Initiative, which is a wonderful initiative that we are working together with Sangath, Empower India, and the Global Mental Health Peer Support Network, where we aim to create a global peer support training curriculum. And we are conducting the systematic review that hopefully will be done by the end of the year, and we will be scripting and have a curriculum by the end of next year. So we are very excited about that project as well. And finally, the Namaste project that is led by Sangath and the University of Manchester, and we are collaborating, that aims to create a digital training for non-specialist providers that want to support parents of children that are on the autism spectrum. So we are currently working on these other projects as well. I just wanted to mention these as they are very exciting initiatives that we have right now. And in terms of future directions, we have Dr. Catherine Sanchez, PI of Baylor Scott & White, was awarded a UO1 grant, where we are going to train undergrads that are on the social work track on behavioral activation, the training that I mentioned before. And once they graduate, they will be incorporated into the Baylor Scott & White system as community health workers. So we are very excited about this project. We also submitted an R01 to continue our work with Baylor with the goal that to collect patients or clients' outcomes. So we can also correlate those with the results that we already have in training. And of course, the implementation of the Spanish behavioral activation curriculum. So this is in a glimpse what we are doing currently at Empower. And of course, I'm more than happy to open or to discussion and start like the questions, Q&A part of this session. Thank you very much.
Thank you so much, Dr. Carmio. This was such a comprehensive and involved presentation, and it's really impressive how you have, and the Empowered team has really brought a lot of this work to other contexts. And I think we have some questions that have come up in the chat already, and I have a few as well. So we can go ahead and get started with the Q&A. One question was related to the content of the knowledge questionnaire during training. If you could just say a little bit more about what is included in the content and how that was derived, and if there's any differences or adaptations you've made to that across contexts.
Yeah, sure. I'm looking for a paper that we have on that particular piece as well. I can, of course, share some information, but I put the link on the chat for you if anyone wants to access that. The knowledge assessments, we have created 3 versions that has, each knowledge assessment has 26 questions, 9 of which are across the same one. Are the same across the 3 different versions. To create those knowledge assessments, we went through a very detailed process that is included on that paper I shared. We create a bank of questions. Experts on the field review those questions, and we selected the best ones. We make sure that, like the anchor items didn't were related to the most important competencies that we want to make sure people understood and learn through our trainings. And then all the questions are practice-based, so they describe a case and select, and you have to select what's necessary to do in each particular case. So we try to create the questions as realistic as possible to make sure that people are able to apply the knowledge that they have been learning in the questions as well. So, and we are also, sorry, the second part of the question was about adaptation. So we are actually adapting all these the more than 75 questions to Spanish for the Spanish curriculum. And for each of the different trainings that we create, we start all over. Like the 3 knowledge assessments that I'm talking about are for behavioral activation, for depression, and for that particular curriculum. But for Empower Youth, for the peer support initiative, and so on, we start the process all over and create specialized knowledge assessments for each particular training.
Thank you. And a related question to that is about the credentialing and parameters of competency. Can you talk more about how you've navigated any issues or how you've defined competency? I know that there can be, some soft skills sometimes that are part of competency, and having consensus about what those are can vary in the field.
Yeah.
So.
Yeah, definitely. Like our competency assessments are adapted from the ones that were created by the WHO on the QUIT platform. So in there you can find both soft and what soft in terms of general skills and also specific skills. So what we have created 5 standardized role plays, and in those role plays we try to incorporate both at the same time. So not only how to deliver behavioral activation or how to conduct a risk assessment or confidentiality, but also how you interact with the other person, with the client, how you ask questions, if your timing is appropriate, if your facial expression is appropriate, and so on. So the goal was to starting from those ones that already exist on the QUIT platform and are available to everyone, so it's very easy and accessible. We adapted them for our trainings and our competencies, and we combined both soft or foundational skills and behavioral activation into the same role play, so we can we can assess both at the same time. And in terms of levels, the WHO has already decided 4 different levels. The first one is harmful, so it will be someone that doesn't have the skills to adequately deliver the intervention. But then you have basic level of skills, basic with some improvement, and then advanced. So we are trying to figure out how to exactly measure and the measurement process is kind of already established, because each of the levels describes very specifically what you should look into those recordings to see if that participant in particular is able to provide and deliver those skills adequately. So that part is already established. It's just a matter of, and this is something of also more related to the implementation with the organization on how where we locate the CAT score and exactly how much level of skill we need. Of course, like it has to be more than basic, right? But it also, the credentialing process is also something that we discuss with every implementation partner that we have, because different organizations have different requirements.
Thank you. That's very comprehensive. And I know I'm familiar with the Equip platform, but I'm wondering, others on the call or who have joined the seminar today might not be. I'm wondering if you could just say a little bit more about what that is. Others might be interested, especially because we have often a lot of clinical psychologists or psychiatry residents who might be interested in intervention development that involves or testing that involves training. And I think these tools are really excellent and very scalable.
Yeah, for sure. I agree with you. They are very useful. They are very intuitive. They are very helpful and very accessible. So it's wonderful to have that tool. And also the team, the WHO team is also very helpful when it comes to adapting those already existing role plays to particular competencies. So that process is great. I have sent the link to the Quit platform. Everyone can register. Once you register, there are different role plays, and all the role plays are competency based for different type of interventions. So you will have like foundational skills that WHO calls ENACT, or behavioral activation, or problem solving. And if you click on those, you will find examples of how role plays can be conducted, instructions for the actors on how they should act in those role plays, but also instructions for the raters, like, well, how you will rate those sessions and what parameters you should consider. They also provide worksheets that have the different type of criteria for each of the levels on each of the competencies. So it's very comprehensive and provides a lot of information on how to measure quality of delivery of care. And also it's very adaptable to different resource settings. So it's really wonderful. And I encourage you, like, if you're interested in taking a look, because it's a very valuable resource.
Thanks so much for sharing that link. I think that would be really useful for many of us. And just like as a follow-up with that, I'm wondering if you've had any feedback or kind of challenges with acceptability of the rating system. I know in some of the work that I've done where supervision is part of it is rating fidelity and competency among the non-specialist deliverers of an intervention. There can be some cultural kind of differences related to how feedback is received or scores are given. And I'm just wondering if you've had any challenges related to just how people receive that feedback or being scored.
Yeah, no, of course. I think like for all of us, being evaluated is always kind of challenging. So in that sense, it makes sense that people might feel a little bit like nervous or something. I think the goal of all these measures is to know how to support people better and how to help them improve if they need some improvement. And also in the mental health field, we like we are always learning, right? It's never like you are never done. So I think like if we can present the competency assessments as one of the many different steps in the learning journey, and to actually prove them and support trainees or providers in their journeys, it's easier and it's more acceptable to conduct the competency assessments than if presented as a yes or no kind of exam. So in that sense, I think the competency assessments is something that we should like all try to do across our lives when providing care, because it helps us practice skills. This is not only meant for assessment, it's also used for practice. So I think that also could be leveraged in a way that people can feel more comfortable of trying different things or wording things different or so on in a context that is much more supportive. For sure, some people have some issues of being nervous or not liking that much to participate in this type of things. But I feel like everyone, like any mental health provider, me as a clinical psychologist, I have to do many of those. So I think it's part of the training, and as much as we can show that the assessments are part of the process of learning, is much better than just like saying that it will like allow them or not to work or things like that. And people were actually very excited, at least in the US context, to get feedback of how they were performing, how they could improve. And I think this is because if you're a community health worker, or if you're in any healthcare, or just talking to human beings, like people have problems and you tend to react in some way. It's impossible if someone is telling you something not to react. So having the skills and the competency to do that in the best way possible gives a lot of confidence and also reduces the stress of like the burden of mental health. So I think in that sense, that also explains why people were so intrigued and interested in getting feedback and learning how they could improve.
That's actually really great to hear and encouraging. And I love this idea of the culture of learning. I think that that's really, such a nice way to frame, this kind of process of training where you are going to be evaluated to some extent, but everybody is learning, and it's just a culture of learning.
Yeah. Yeah.
That's great. Okay, we have some more questions here. We have another comment, just a lot of positive feedback about how great your talk was. And another question about the intervention. So for depression, there are many evidence-based psychotherapeutic interventions. And why was the app focused on behavioral activation as opposed to other types of evidence-based treatments for depression? And then secondly, could you speak about which cultural considerations for behavioral activation were incorporated into the app?
Yeah, sure. I'm taking notes so I don't forget. Yeah, why behavioral activation? We chose behavioral activation to be digitized and have a curriculum and incorporate it into the Empower platform for many reasons. First, it's a very short training, it's a very short treatment. So it can be delivered in 6 sessions, which in community-based settings where people are already working and have a lot of responsibilities, having a very short intervention that has proven to be effective across the globe is amazing. It's the first way to go. Our program of behavioral activation has some components of problem solving as well, but it's mainly behavioral activation. And the decision-making process was, as I mentioned before, based on the literature review, the expert feedback that we got, and also in collaboration with the communities, taking into consideration also feasibility, how long what's the time availability for someone to be trained, and also how much time community health workers or frontline workers have to actually deliver the intervention. We want to make sure that what we create is feasible and doable in real life settings. And behavioral activation have all those components in terms of being like scientifically effective and valid. It's very like, it's across the globe. So that's also reassuring. It's a very short and is a key ingredient that has been proven like in many, many settings. So, and also, well, throughout the process of selection of the intervention, it also came out as the big intervention to scale. So that's why behavioral activation and also Empower aims to create to collaborate with specialist providers. I'm myself, I'm a clinical psychologist, and we work with other specialists. And we aim to create like the first line of treatment in community settings that produce the better outcomes in those settings. If people, of course, there are always challenging cases and those cases, and we make sure that frontline workers have referral paths from the beginning. So if they encounter a particular case that needs a higher level of or more intense care, there is a referral pathway already in place for them to refer out. So for sure, we don't believe that behavioral activation is the only treatment for depression, but for sure it is an effective, short, proven treatment that could be delivered in a community setting by non-specialist providers very effectively as well. And then in terms of cultural considerations, for instance, for the Spanish adaptation, the literature shows, and if you talk with anyone from the Latino community here in the US or outside, mental health is surrounded by a lot of stigma. So for instance, talking about mental health problems, mental health diagnosis or mental health issues is a little bit too strong in Spanish. You wouldn't say that. People feel like, oh, I don't have that. I don't want to talk about that. It's not like a very comfortable conversation. So how we frame that and the wording we use to also incorporate issues that are very important for the Latin community in the US and the people in those communities that have actual problems such as could be immigration or religious issues or so on. We also incorporated those into our trainings. So that's why it's not only a translation, but it's also a cultural adaptation.
And did you use participatory processes for some of those cultural adaptations too, in terms of like what might need to be considered? Like you mentioned immigration issues or religious issues. Was that based on participatory work?
Yeah. Like 10 community health workers that review the whole curriculum, and they were recruited by people in the local communities. So they review the whole training, and we develop a very specific guide of questions or things that we wanted to ask them about. And it incorporated like the settings of the videos, how the actors look, but also how we were wording and what were the issues that were addressed during the training. So they were the ones that told us what the people that they were serving in their communities were facing, and what they will feel like it will relate and reflect more appropriately what they were going through. So yeah, for sure.
That's great. And I'm sure that helps really with the ultimate acceptability and fit of the interventions.
Yeah, exactly. Yeah.
Great. I have a question just about the extent of scale up that you have and that you're embarking on here with this work. And what implementation strategies have you considered or used to help support scale up? And if you haven't used any specific ones yet, I'm wondering what you would recommend, because I think scale up is on the minds of most people working in lower and middle income countries or low resource settings in the US or rural settings where services are limited. And how do we really scale? Like what strategies work to scale these evidence-based interventions and evidence-based trainings, which is what you've really worked on. Yeah. It's a very evidence-based training.
Yeah. No, I think that's a great question. And it's something that we are also thinking about right now. In India, the ashas are government workers, so they are already working with the government. And in terms of sustainability in long-term scale-up, that's, of course, the best way to go, because you can ensure that that training and that delivery process will be delivered across time. And also because we are our training incorporates the peer supervision part, but also at some point those peers become experts once they have the adequate level of competency, so they can also supervise new cohorts of trainees. So it's a system that in the long run is very sustainable. but of course it needs funding, both in terms of people having the time availability to take the training and also to deliver the training, because frontline workers are usually very overworking. So having the government involved and having local policy and public policies supporting this type of initiatives is always the best way to move forward and to ensure the scalability is doable. We are thinking about different other avenues in other resources. Empower at Scale is an outside organization that help us scale outside of Harvard all the Empower curriculum. Because of course we are an academic setting, and what we aim to do is to create the curriculums and to produce knowledge and all the science to support the scale up, but the actual scale up, we don't have the resources, and it's not our main role to actually do the scale up. So Empower at Scale, it's an outside organization that is currently working on scaling our interventions in different settings. For instance, in Chile, we are talking about scaling the Spanish adaptation curriculum, and that process also will incorporate local governments, municipalities that are supporting, that want to tackle the mental health crisis, and they want to use this model. In the US context or in other contexts, I feel like this model is getting more and more traction, and people are getting more interest. And we are working with different health systems to see how this model could be incorporated into their current into the current structure and organization. So for instance, incorporating this model as a way of increasing the people's career paths, and also to be part of the continuing education credits, and also to incorporate this as part of the yearly training programs and so on. So I think there are different avenues, and I think always sustainability is the next big challenge, and we are exploring different opportunities.
It really sounds like there are a myriad of strategies that you're using in different contexts, but it sounds like one of the key ones is really just building these partnerships, these government and non-government partnerships, depending on the context. And would you describe your training approach as a train the trainer approach to building capacity, or is it a different type of model that you're using in terms of kind of building out the workforce and the expertise?
Yeah, definitely. Our goal is to train the workforce and to create a workforce that can help us reduce the scarcity of mental health professionals or care providers in different community settings, and task sharing has proven to be very effective across the globe. So there is no reason why it cannot work in the US or in other settings that haven't been traditionally associated with task sharing. And in that sense, it leverages the relationship that the frontline worker already has with the community. It also frees up space for specialist providers to actually pay attention to the cases that require a more complex level of care. It's also very effective. So in that sense, it's the best way to proceed. So hopefully we will be hearing much more about task sharing in mental health in the years to come.
Yeah, I agree. I really hope that this is just the beginning of bringing lessons learned from the global South to the global North. And one of those key ones is the task sharing to help address all of these mental health treatment gaps that we also have in the US.
Yeah.
And in higher income countries, actually, just in general. Yeah. So,
yeah.
Well, this is just fantastic. So comprehensive, such amazing work. We're so happy that you're able to join us today. We only have 1 minute left. Any last minute tips for anyone or lessons learned in bringing these methods from the global South to the global North?
Yeah, no, I think it's very exciting what's going on in the mental health field right now. I think there is no better time to get engaged and think and collaborate with others. And I'm more than happy to continue talking if anyone is interested. My email is on the slide deck, so please reach out. I'm happy to continue this conversation. And thank you for inviting me today.
Thank you so much. And thanks to everyone who joined in today. And this was our last talk for the fall seminar series. So we hope that many of you will join us next year. Thanks so much, everybody. Take care.